Hi, my name is Kyle Doyle. Today I'll be demonstrating X-ray setups of the tibia and the fibula, as well as the knee. So these will all be done at an SID of 40. Most will be done in a tabletop position with shielding over the lap. The tibia and fibula ones will be done on a 14x17 cassette. So first we're going to do the A to P tibia and fibula. So the leg will be extended with the posterior leg resting on the cassette. Our central ray will be perpendicular to the shaft of the tibia, and collimation will include the tibia and fibula, as well as the knee and ankle joints. Next, we'll do the lateral tibia and fibula. So the patient's lateral leg will be resting on the cassette. The central ray will be directed perpendicular to the halfway point of the shaft of the lower leg, and collimation will include the tibia and the fibula, as well as the ankle and knee joint again. If the leg is too long, the leg can be stretched out obliquely across the cassette to include both joints. Next, we'll be doing the knee views, so that will be on a 10x12 cassette instead of a 14x17. So first we'll have the A to P knee, side marker there. So our central ray for the A to P knee will be directed perpendicular to the knee, a half inch below the apex of the patella, or if the patient is recumbent, we'll be doing a 3 to 5 degree angle directed cephalad. So the patient's leg will be extended here with the posterior knee resting on the cassette. Collimation will include the distal femur, the patella, and the proximal tibia and fibula. Next, we'll be doing the medial oblique knee. So leg will be extended still. The patient's leg will be internally rotated 45 degrees. And our central ray will again be directed perpendicular if the patient's seated, or 3 to 5 degrees cephalad if the patient's recumbent, and a half inch below the apex of the patella. Collimation will again include the distal femur, the patella, the proximal tibia and fibula, and this one will give a clear view of the proximal tibiofibular joint. Our lateral oblique knee, so leg will still be extended, and this time the patient's leg will be externally rotated 45 degrees. Our central ray will still be directed perpendicular to the knee if the patient's seated, or 3 to 5 degrees cephalad if recumbent. 1/2 inch below the apex of the patella. This will be collimated to include the distal femur, the patella, and the proximal tibia and fibula. Next, we'll have the lateral knee. So the knee will be bent 20 to 30 degrees and resting on the lateral side. And our central ray will be directed 5 degrees cephalically, a half inch below the apex of the patella, or a half inch below the medial epicondyle, and collimation will again include the distal femur, the patella, and the proximal tibia and fibula. Next, we have the tunnel knee. So one sec, I'm gonna have to change my setup here a little bit. So this would be the 10x12 cassette. I'm using my 14x17 one because it sits flatter on the ground, but anyways, for this one, the patient's normally will be in a standing position, but I'm going to be doing this laying down just to demonstrate it more easily. So the setup will be P to A, so the anterior surface of the thigh will be on the cassette with the femur parallel to the cassette. The leg will be flexed 40 degrees. The central ray will be perpendicular to the lower leg and will exit 1/2 inch below the apex of the knee, or 1/2 inch below the apex of the patella. And so this on the posterior side will be about 2 inches superior to the knee at a perpendicular angle to the lower leg. Collimation will include the distal femur and the intercondylar fossa. The tibial spine and plateau will be viewed, as well as a clear view of the knee joint. Next, we'll have the tangential patella. So the patient's knee will be terminally flexed in the same P to A position. And we will typically do some sort of wrap to hold the patient's knee in that position, such as tape or gauze or something. Our central ray will be directed 45 degrees to the lower leg, which is about a 10-degree cephalic angle. Again, it will be directed through 1/2 inch below the apex of the patella. And then our collimation will will show a clear view of the patella and the space between it and the femur. And that is it for today.